Hey guys, I'm taping this test review for you just to kind of focus your um, investigation for studying for the first test. In terms of best actions for encouragement of patient safety, just remember the Speak Up program, and there are very key things related to the National Patient Safety Goals that we particularly go over with patients on admission to remember to let us know if they notice that people are, not flushing lines using the amount of time on the clinic cleaning the hub, or they're noticing people coming in and out of the room not washing their hands before and after care. Um, so just all those different kinds of things that patients would do, and usually getting them involved in that and feeling comfortable letting you know and being open to them letting you know if something you're doing is incorrect will help them be more um, involved and remind us more things that we need to be sticking with all the time, because safety is the biggest priority for nursing. And first do no harm is a big thing for nursing. Secondly, just to remember that even though we've done tons of things with medications in terms of barcode scanning and all that, medication errors still are the most common errors that occur in the hospital. SBAR, we've talked about again and again, just again to reinforce what those components are so that we really get in the habit of using that all the time in our communications for key changes in conditions or issues that come up, and how we go about concisely reporting that to team members or to the physician. We talked a lot about continuous surveillance monitoring, and how doing vital signs at intervals doesn't capture something until way many hours later, when perhaps we would catch things, complications or trends earlier if we have continuous monitoring. So just be aware of that. You guys gave great examples of practice drift examples. In your slides, there is a specific definition. Make sure you know that. Um, Also, in the guest speakers that you had, they had good information of very specific, typical declines of the elderly, and by that I mean just body systems that have issues and do decline with age, and then other symptoms that come from those declines that you might notice. Um, they also, in the discussion, gave specific percentages of the incidence of delirium that occurs. And by incidence, I mean the percentage of elderly patients that you would see in the hospital that would develop delirium. And remember that, in terms of the characteristics of delirium, what kinds of symptoms that they have, as well as that delirium can last after, even discharge for a while. It may not resolve right away, and you have to educate people to be able to handle that. And then, we discussed a lot about, what interventions that are appropriate to try to reduce delirium. Those were also included on your slides. And how interventions for delirium are different than dementia, because dementia is more of a permanent condition versus delirium. And then common causes of poor appetite. Um, we often think that it's just, lack of taste. Sadly, though, many elderly people do not have finances to really always choose between medications and food on the table. So, if you're trying to look at a hierarchy of assessment for these things, looking at finances and transportation to even go get food is really a beginning point. And then if they have food and have the ability to have food, then, do they have, problems with their dentures? Do they own dentures? Do they have, the ability to cook and prepare their food? Um, as well as, things like how is their actual appetite? Um, do they have symptoms of indigestion? And then maybe looking at what did they eat, in the last few days to look at commonalities. So just try to think about when you're trying to assess for appetite, it may or may not be a condition of do I feel like eating. Um, and sometimes medications can be at the root of that as well. Um, Common causes of confusion. Medications can cause confusion along with delirium, dementia type symptoms. UTIs, as we've mentioned several times, are a huge thing that lets you know that they're beginning to have some type of infection. They may have signs of confusion before it even shows up, the infection piece. Um, Another idea is how do you really help older people self-administer medications? We talked about polypharmacy, and if they have to take certain meds at a certain time, one of the easiest ways to kind of do that, a lot of people will use pill boxes, but even that sometimes gets patients confused. So if there is a way to color code things, that will help, with the caveat that you really ensure somebody has not got, color blindness, and then you might have to get some other mechanism for doing that. But long list patients usually cannot follow as well. So, anything that you can simplify like that, and color coding if they don't have color blindness is one of the key things that tends to help them. Best pain management, just knowing that often elderly people are under medicated for pain, and that it is okay for them to take drugs that are strong, like Dilaudid, when they do have severe fractures or severe pain, surgical pain. We do have to be concerned with what is the drug half-life in the elderly. So things that are short half-life are going to sometimes stay with them just a little longer. So we have to kind of watch in terms of the frequency of medications being given, and to kind of really see each person's a little different. They metabolize things a little slower. So, just kind of watching, it's not that they can't have a strong drug, it's that you really have got to evaluate how long was it staying with them. Actions to deal with informed consent. We talked about some examples of that in class. If a patient is confused, even if they're intermittently confused, you cannot really have them signing consents. It really needs to be a dedicated person that they have decided that is either first a legal healthcare power of attorney. If that's not in place, then you would move to next of kin, and that's pretty clear. We talked about that in class quite a bit. And also, it's really the very best idea when this situation comes up to not handle this on your own. So if you have this come up, the very best intervention first is to really go and talk with other members of the healthcare team to make sure that we're all on the same page as to who we are all going to go to as the next of kin or that dedicated person. It's not okay for one of us to be getting consent from the nephew one day and someone else getting consent from somebody else the next day because I couldn't get somebody on the phone. And as we talked about, if it is really an emergent situation and that's going on and we can't get someone, two physicians can attest to the emergent nature of it and do it that way versus getting the wrong down the line person to sign something. So it's not based on who you can get. And so the best thing to do is always as a team ascertain who are we all going to use, and that person has to be the one that you get consent from. we talked about the timing, and I know y'all have memorized that to a degree through your assessments of when would capillary refill be considered abnormal, and proper ways that you can assess it, and on some patients you can't because of the condition of their nails. Just as we talked about in class with intermittent claudication, people with peripheral arterial disease will have that where they have pain with more and more ambulation. They also may have very risk for falling because of lack of sensation. But usually, claudication will decrease with rest. And that doesn't happen with 100% of people, but that is usually the common thing that you see with that. And then potential barriers to foot care. Clearly people, if they don't have sensation, they may not know that there are cracks or sores or wounds or problems. And, sometimes they're not physically mobile enough to be able to take care of their feet. If they have, terrifically hardened toenails or that are, have fungal infections or things like that, they can't always cut their toenails. So those are just a few barriers that they may come across. We talked a little bit about people going and having PTCAs and other things to kind of clean out their vascular system if there's blockages. And any of those types of interventions or surgeries, clearly our main assessment that we're focusing on is, has there been return of circulation, and what is the pulse quality in that affected extremity. So that is really, what you're really, really following in terms of perfusion to that particular limb. Know what if you should have throbbing pain after a FemPop bypass. What kinds of things might you do to relieve that? That's a pretty common condition. And then, as we talked about with the heparin drip, Alteplase, is a strong anticoagulant, and so, or antithrombin. And so if we're really trying to see what would you do with confusion, it's not any different than in your heparin protocol example. Someone's gotten something that is going to create a situation that they might start bleeding internally. So acute confusion could be one of three things. It could be the person's just confused for some reason, whether that's an infection, whether that's delirium, what have you. It could be that the person has thrown a clot and now they're having confusion symptoms because they have a CVA, or more scarily, they could be having an intracranial bleed. And so when those kind of conditions occur, you want to get rapid response on the scene as quickly as possible, because whatever treatment needs to be rendered, you're going to need a team to handle it. Often before anything can be done, they may want to take them down for an emergent CT of the head just to verify. You're not going to, are you going to give blood thinners because you think it's a clot? Obviously no, until you know whether there's a bleed up there present or not. Another thing about abdominal aneurysms, this is where an extra lumen is created in the aorta, and you can have abdominal cavity bleeding, and so it's very important with that going on. We don't do percussion. We don't do a lot of palpation, obviously, of the abdomen. to check out the abdomen, even though that's sort of a typical assessment that we do for abdomen